Xeroderma Pigmentosum, a presentation created for MLSCI 480 by Becca, Elaine, Emily, Jessica, and Kayla.
The first section we will talk about is the genes associated with this disorder. Xeroderma pigmentosum, we'll call it XP for short, results from mutations in DNA repair genes, specifically ones involved in the nucleotide excision repair pathway. This pathway functions to identify and repair damage. As a result, XP patients have defective repair systems and thus cannot mend UV-induced damage to DNA. Listed here are the many possible defective genes and their protein products, which are in brackets, involved in XP. There are 7 XP groups, such as XPA, XPB, all the way to XPG, and they represent distinctive subtypes of XP with different DNA excision repair defects. We will talk more about XPV in the next slide. There can also be mutations in the DNA excision repair gene, ERCC, or mutations in the GDF gene that encodes for transcription factors involved in DNA repair.
Here we have 2 tables summarizing the DNA repair genes, their normal function, and the clinical consequences of mutations in those genes. If we look at the first example on the left table, the XPA gene is responsible for encoding the XPA protein, which functions to unwind DNA for repair. Mutations in this gene will result in disease characteristics such as sensitivity to light, poikiloderma, which are brown patches on the face and chest, lentigines, which are spots of pigmentation, destruction of neurons, and an increased risk for skin cancer. One variant that I alluded to earlier, XPV or XP variant, patients have normal nucleotide excision repair but are defective in their DNA replication. Normally, XPV encodes a DNA polymerase that is capable of replicating UV-damaged DNA. However, mutations in XPV results in the polymerase being unable to bypass the lesion and thus causing defective DNA replication.
Because the disease is caused by multiple variants, we will only be focusing on the most common variants. The most common variants are XPA, XPC, and XPV. The most common variant reported in the US, Africa, and Europe is XPC, whereas the most common variant reported in Japan is XPA. And finally, XPV makes up 30% of all cases.
Next, we will discuss mode of inheritance. The mode of inheritance of Xeroderma pigmentosum is autosomal recessive. This means that an affected individual has 2 copies of the recessive allele that leads to the development of this condition. As well, Xeroderma pigmentosum has 100% penetrance, which means that if the recessive genotype is present, the likelihood that Xeroderma pigmentosum will develop in an individual is 100%.
On to the next section, frequency and phenotypes. Prevalence in Japan is estimated to be 1 XP patient per 22,000 people, while in Western Europe and the USA, it is estimated to be 1 per 1 million people. For the death rate, a study found that 34% of 29 patients died from skin cancer, 31% from neurological degeneration, and 17% from internal cancer, meaning cancer that is not skin cancer. For spontaneous abortions, none of the mothers of XP patients experienced any complications during their pregnancy. For lifespan, a 4-decade-long study found that the median age of death overall for XP patients who died during the study was 32 years. They found that XP patients with neurological degeneration died around the median age of 29, while those without died around 37. Phenotypes. XP can present severely, mildly, or without neurological abnormalities. 100% of patients present with dry skin, patchy discoloration, and freckle-like lesions on exposed skin. 90% of patients have ocular abnormalities on sun-exposed parts of their eyes and eyelids. 65% of patients experience abnormal skin growth. 60% of patients, upon minimal exposure to sunlight, can get an acute sunburn. The image on this slide shows different skin conditions of XP patients. Pictures A, B, and C are the same patient at different ages. Patient E has been protected from the sun since their diagnosis at birth. So next we're going to talk about the diagnostic tests done for Xeroderma pigmentosum and a few mentioned in the literature. APL does an XP next generation sequencing panel to look at these genes: DDB2, ERCC2, ERCC3, 4, 5, XPA, and XPC. The literature also states that you can do ERCC1 as well as POL-H. This can be combined with family history and the patient's clinical history in order to diagnose Xeroderma pigmentosum. For the rare diseases, it may be cheaper to have DNA sequencing done at an allocated lab, but in the case of XP, there's so many alleles to look for that the resulting assays for DNA repair or UV sensitivity can be used to help alleviate this. A small study examined the use of IHC on paraffin-embedded tissue blocks for diagnosing XPC in skin biopsies, and indicated that IHC could be an alternative method for diagnosis where XPC antigen can be detected. Samples need to be tumor-free biopsies or tissue-free of extensive sun damage, as XPC antigen reappearance does occur on these sample types. Considering Japan has a large proportion of XP cases, we investigated their guidelines and testing. Some of the tests they listed were photosensitivity testing to look at the patient's sun exposure, and they also suggested assays to test UV sensitivity or DNA synthesis. Genetic or gene product analysis can also be done. Here is a flowchart from the Japanese Dermatological Association guidelines used to reach an XP diagnosis. There is prenatal testing that can be done. Amniotic fluid cells from an amniocentesis or chorionic villus-derived cells may be used for DNA testing to produce prenatal diagnosis for those with family history. With these cells, we can observe for activity in the UV-induced DNA repair. Another study also used genetic questionnaires in combination with chorionic villus sampling or amniocentesis were used to provide a prenatal diagnosis to a small sample of families that had an XP child. Mutations were screened by direct sequencing, and then these were amplified and sequenced again. Parents were also checked for heterozygous mutations before any prenatal diagnosis was carried out.
And for our last section, we're going to be talking about therapy and treatments. Unfortunately, there is no cure for XP. However, there are preventable actions and supportive therapies available to help patients manage. People with XP are advised to avoid the sun by avoiding outside activities during the day. When going outside, this includes wearing sunglasses, covering their head and neck, wearing dense, darker, tightly woven fabrics, and using sunscreen, at least SPF 30. They should avoid artificial lighting, including light from metal halide lamps and some fluorescent lamps, and measure UV light in their homes with a light meter. Extra measures to protect against the sun can include installing UV blocking film on windows in homes and cars. People with XP should also take vitamin D supplements. Frequent visits with a dermatologist can help patients manage their skin condition, appearance, and limit the spread of skin cancer. Most common therapies include retinoids, dermabrasion, and photodynamic therapy. Because there is no cure, the most commonly used therapies focus on the management and prevention of skin cancer, but new research shows that there is a possibility of a treatment in the future. One example of a gene therapy targets the XPA gene mutation. Some researchers theorize that acetohexamide,
a medication typically used to treat diabetes, can minimize the harmful effects of UV ray damage. Acetohexamide may promote the degradation of a DNA glycosylase involved in the base excision repair pathway. Many novel approaches like this demonstrate successful treatment in single case studies though, so more research needs to be done. As previously mentioned, it is most recommended for patients to avoid the sun and wear protective clothing, like this stylish individual in the image on the right. Thank you for watching our presentation on Xeroderma pigmentosum.